Okay, great. Hi, everyone. Welcome to this webinar focused on non-invasive screening and genomics in NAFLD. Really excited to be here with Neeraj and Wayne from the Fatty Liver Foundation, who you're going to be hearing from shortly, and they'll be spending about 25 minutes going through some of their learnings from the past few years on this topic. Just to give you a quick overview of the agenda, I'm going to give you a really short introduction to Sano and what we do. Then I'm going to turn it over to Wayne and Neeraj from the Fatty Liver Foundation, who are going to take you through about 10 or 15 slides focused around screening for undiagnosed NAFLD and NASH, and a lot of learnings from the SUN study that they ran not too long ago. Please at any time send your questions through the chat. If you don't know how to use the chat function, then it should be, if you're on a desktop or laptop computer, it should be across the bottom of your screen. On a phone, you may have to click on the ... on the bottom of your screen to access it. But please feel free to use the chat or the section labeled Q&A and just stick it in there, and we'll either get to it as we're going if it pops up, or after the presentations of the Q&A section. Then after the webinar, we'll follow up with a webinar recording as well as a blog post with some of the key takeaways and I think a time-stamped video. So be on the lookout for that. It'll be a couple days. It'll probably be next week by the time we get those turned around, but just be on the lookout for it. And then finally, if you're on social media, feel free to live tweet things, and we've got a hashtag there, hashtag Sano Speakers, if you want to use that. Okay, great. Just a quick overview of us and what we do. What we've developed is a platform for patient-centric medical research. So we have an online platform that allows patients and people who want to take part in research to find research that's relevant for them, as well as personalized content and other information. We've developed an at-home testing kit for whole genome sequencing, exome sequencing, and other kinds of genomics. This is used in clinical trials as well as other kinds of research and development programs for early detection and screening. And we've been developing our platform for use in large-scale precision medicine initiatives. The furthest along here is through a collaboration with Genomics England. What we're aiming to really deliver is a much better research experience for participants. So this includes simple things like updates on the contribution that you're making, notification about new research opportunities, and ways for research participants to get value back from taking part in the process, and really to be in control of your data and understanding what's going on when you take part in a research study. Here's just an example of one of our participants completing one of the at-home DNA testing kits in the context of a COVID-19 related study. So these are easy, straightforward at-home tests that allow people to take part in research or screening from their homes. So I just wanted to talk a little bit about what we mean when we say personalized medicine, because this talk really is focused around personalized medicine, whether we believe it or not. And for us, this boils down to 5 core Ps: prediction and prevention of disease, more precise diagnoses, more personalized and targeted interventions, and then a more participatory role for patients. And I actually think we're probably going to hit on all 5 of these today. And this is I truly believe we're in a period of transition from non-personalized to personalized medicine, and that involves making substantial improvements across all 5 of these areas. And so if we split that into a grossly oversimplified and high-level view of what our healthcare system and the way drug and therapeutic development works today, if we think about 3 broad buckets: discovery, development, and then delivery to patients, where we think personalized medicine has a role to play, not just in NAFLD, NASH, cirrhosis, but in most diseases, is from the earliest stages of drug and biomarker discovery. How do we find drugs that work better for genetic subtypes or patients identified by some other piece of data or biomarker? How do we get these drugs through clinical trials to prove that they're safe and effective in patients? And I think we're going to talk a little bit about that today, because we know there's a huge bottleneck at this particular step when it comes to NAFLD and NASH. And then ultimately, how do we deliver a healthcare system that embraces early detection and prevention rather than reaction at too late in a disease course? So I think we're going to talk more about these themes, but this is the way that we think about developing and delivering precision medicines. So I'm going to hand over to Wayne and Neeraj shortly. I just want to highlight some of the challenges from our perspective based on the work we've done and in our understanding in NAFLD and NASH. Probably the biggest one is delayed and underdiagnosis, and I think we're going to spend a lot of time on this today because this cascades to all of the other issues. One other big issue is the over-reliance on invasive liver biopsies, and I think we're going to talk about some non-invasive technologies and the way this can enable some larger scale efforts to screen patients. A third one, which is really a symptom of both of the first two, plus some other things, is we know we have a huge set of challenges in clinical trials, in particular when it relates to recruitment. And I think Wayne's going to touch a little bit more on this, but we think there's probably a need to diagnose about 10 times more people than we have today with NAFLD and NASH in order to meet the requirements of all the trials that are active. So this is an enormous problem. And it means that at this critical step of getting treatments to patients, we run really the risk of massive delays and cost overruns. And then a third point here is trial endpoints are often most focused on the most severe end of disease, which poses a challenge as well, because it means only a very small fraction of patients are likely to be eligible for this. And patients often go through a lot of time and screening only to find out that they're not eligible. And finally, one that's probably not as big of a challenge for most of these groups, but is an emerging one, is there's a number of studies that are starting to target genetic subtypes or people carrying genetic risk factors for NAFLD, NASH, and cirrhosis, including the gene PNPLA3. And there's additional challenges here, which is that genetics is not mainstream in the context of this condition or many others. So it means that all of the issues above when it comes to trial recruitment and R&D are compounded further by the fact that there's a subset of patients with a genetic factor that are not generally screened in the healthcare system. So one big, and it's really simple to say this is a solution. I think Wayne and Neeraj have ideas on how we can get there, but large scale and non-invasive tools and approaches for early detection and management can really help us to solve a number of these challenges and ultimately improve prospects for patients and people who may not actually know they're at risk. So I'm going to stop screen sharing and I'll turn it over to Wayne and Neeraj. And I think Wayne is going to screen share. And as I said before, please feel free to drop questions in the chat as we go.
Oh, gee, thanks, Patrick. That was a great summary. We have quite a group of a variety of folks here, so I thought I might just give a short view of how what the patient journey is like, because it is different for everybody, but it is I could easily spend the hour talking about that. But I'll give you a sense of how it is today for what patients are doing, and then a little sense of where we would go. So the Fatty Liver Foundation was basically, I'm the CEO and the founder of it, and I am a cirrhosis patient. And it's because of my experiences that we created the foundation. But if we look at the problem, we have 100 million people that have fatty liver disease, and very few of them know it. We have about 35,000 people that will need to be identified for the screening that's going to take place for the drugs that, it's just an enormous problem that we have. And from a patient's perspective, the fact that we have no therapy is very, very difficult for us. It's a tough thing as a patient to be told you have cirrhosis and we have no treatment. And that's what most of us go through. I'll give you just the briefest sense of what that's like. For me, this is my personal journey. I was incidentally discovered in 2010, but then they decided I didn't actually have a problem. So I went from 2010 to 2015, going from what we look back on as probably an F2 NASH, which is a serious condition, to when I was finally diagnosed in 2015 with stage 4 cirrhosis. And most people don't get to look at their slides, but I volunteer for things, so I get these pictures. And during that period of time, I had a lot of tests, but none of them showed anything. And that's one of the things that has been wrong in the past, which we're looking to see fixed as we go forward. And I think that's one of the important messages that we'll talk about here today. In my personal journey, and the reason that we are so high on testing is I wanted to just share this bit with you. For anyone who doesn't know, briefly, FibroScan came out in 2014, I think. My hepatologist was one of the early adopters. And so I was tested with FibroScan in 2015, and my score was 21.5. And at that time, we were declaring cirrhosis at a 12. So, that was pretty darn serious place to be. But over time, I've been able to reduce my my liver stiffness and to resolve most of my problems, so that I'm now in a very stable position, and my FibroScan is a 9.6, which is a high 3. Now that is really important, because most people are unsuccessful at this. And one of the things that we believe is that if people are able to test along the way, they have a better chance to succeed. And I did. I was able to have a little more monitoring than most people, and that was very helpful to me in resolving my particular situation. And it was that process, my dismay as I looked back at how difficult it was, because there was no effective testing when I was going through my multi-year diagnosis period. And then the value to me of being tested through my therapy time to a point where I could be stabilized, and to realize how few people had that opportunity or were able to get to the place that I was. And that's what led to the creation of the Fatty Liver Foundation, really. And so our mission was to improve the diagnosis, treatment, and support of people with fatty liver disease. And one of the things that we are frustrated by is, and it's the source of a lot of the problems that we have, is that we do not, in America, screen for early stage disease. We do not look for advancing but asymptomatic disease as part of our standard guidance. That's not the case in Europe, for example. And so, that's a policy that the foundation is actively advocating that we change. So, and as our part of how do we go about getting proof that you can go out into the community and make a difference. And we created the Sun study, which looks at this dynamic, if you will. We know there's 100 million people that have fatty liver disease. There's 85 million that have prediabetes. There's 29 million that have diabetes. These are treated in silos. You know, we're in medicine these days, you know, things are so much siloed by organ. But when we think about liver disease, it's comorbid with so many other things that we choose to think about this at a person level. And if you just look at the metabolic combination of fatty liver disease and diabetes, there's about 40 million people that need to be screened for these diseases. And, you know, that's an enormous task, but it's really speaks to how difficult our public health is, because imagine that these people already have active disease. It's going to progress. Non-communicable disease is something that just progresses over time if you don't deal with it. And that's just an enormous burden that's coming at our medical system and at our society. And the result is premature death and an unhappy last decade of your life. So the first part of the Sun study we started in 2018, and in that we took a FibroScan out into the community. So this is different from which is what is typically done, which is that the patient goes to the doctor and the doctor does stuff to them. And we said, you know, the doctor's not doing these things, is not looking for these diseases. So can we go out into the community, and will the community accept being tested or want to be tested for asymptomatic disease? And that was the Sun study. And we set out to screen 1,000 people with a FibroScan, which we actually did in 2019. And we got a lot of different kinds of results, but just quickly, some things that are really interesting is we think of cirrhosis, for example. You know, I'm chronologically superior. I got a decent number of years under me, so you know I'm out on the end of this chart. But when we did our screening and this was volunteers, what we found was that most of the people coming in to be tested were in their 40s. You know, we don't think of liver disease as a young person's disease. We don't think of it as people who are in their child rearing years. But in fact, that's really what we found. It's you know, clearly the 40s and 50s are our biggest periods when people were concerned enough to be tested. Now that didn't go out and test everybody and say, well, this is how it's actually distributed in the society, but these are the people that that cared, if you will. And if you look at some of the results there on the right, you can see that, you know, 73% of these people had liver fat. So they have steatosis as measured by the FibroScan, which is, you know, a huge number. I mean, that gives you, you know, just a shocking, it's a shocking number to think that 3/4 of the population actually has a fatty liver. But even more scary is that 18% of those people had NASH, which is when the scar tissue begins to form in the liver. And that's what you saw in my slides. You know, that's the thing that, that's the process that ultimately will kill you. And 17% of that population had measurable stiffness. So those are really worrisome numbers for a society. We demonstrated that people are willing to be tested, that it creates a teachable moment, that it gives us the ability to educate people, that it can be an effective tool. So we were very pleased with the study, and our plan was to follow that with what we called Sun 2, which was supposed to do this study with 20,000 people, but COVID blew that completely out of the water. So we're working with a little bit different environment right now, but we do still plan to continue the Sun program. And ultimately, our goal is to see 1 million patients a year screened for asymptomatic disease. But to go more to the subjects that we're talking about today is the advancement of non-invasive screening. And this is just so exciting to us because the huge problem that we have beyond the question of we don't have therapy yet is that we need ways that we can identify a disease when it's asymptomatic, when it actually, you know, is easiest to deal with. The whole wellness program, the concept of precision medicine and reaching into the life of a person at a time that is best suited to lead to their health. And so this is an example of the kinds of tools that are being developed today. And this is a blood test, which is called liver fast. It's done by Fibrognostics. And I'm personally using this as a way of monitoring my status because, you know, I have a serious amount of cirrhosis and I can't be casual about that. So the kinds of things that we want are blood tests or other kinds of tests that can easily give us information, and to do it in a form that we can understand fairly easily. And in this case, for example, you can see that this says, you know, I have significant fibrosis, which we know from my biopsies. But importantly, I don't have any inflammatory activity in my liver, and I don't have liver fat. And those are the two other measures, and I can look at that and I understand it intuitively. And this tracks very well with my other tests with the FibroScan. And I've had the MRE, you know, magnetic elastography, various, you know, I'm a kind of a guinea pig, but you know, these are the kinds of tools that we need to see deployed on a broad basis. And where we're hoping to take things is to what we call precision liver health, where we have combinations of non-invasive blood markers, genetic tests, mechanical tests such as the FibroScan, you know, that this combination can be done at the time in a person's disease when it's possible to not have them become ill. And that's really the whole point of the thing. We don't want to become ill. So the vehicle that we're choosing to use for that, we call the Wellness League. And on the right there, you see what people have been calling my octopus slide. But if you think about our society, we have all of these channels of communications that are all pounding on the patient community with messages of all kinds. And it's very difficult for patients to get, you know, to be able to traverse the whole messaging. And then we want to find ways to make that easier for people, but we also want to bring the various siloed disease modalities together. Liver and heart are very much related. People die of heart disease, but a contributing factor is the liver. We have the whole metabolic thing we talked about. We have all the gastro people. We have all the other non-communicable diseases. So finding ways to think of this as a whole person as opposed to, well, you're a liver patient, you know, you're this pigeonhole kind of patient. We want to eliminate those kinds of things. And this is too complex to spend, you know, we can spend time here, but basically it kind of illustrates, you know, the magnitude of the problem. We have this huge problem in America because we have all of this need, we have all this oncoming disease burden, we have all these tools that are competing, we have all this competitive research, we have all the regulatory people, we have just this tremendously complex situation, which we have to try to make more friendly and comprehensible to the patient, and the Wellness League is our way of attempting to make better sense of that over time. So that's my story, and I'm sticking to it.
Wonderful. Thanks so much, Wayne. Neeraj, I just wanted to invite you to introduce yourself as well, and add anything on top of that you'd like to, and then we'll move into the Q&A.
Thanks, Patrick. And Wayne, it's always a pleasure to hear your story. I'm the medical officer of the Fatty Liver Foundation. And while I handle the medical side of the work of the Fatty Liver Foundation, Wayne is not my patient. But looking back at my time in clinical practice, I actually wish that all my patients were like this. So what is typical of Wayne is, of Wayne's journey that can be extrapolated to many patients is the fact that fatty liver disease can often be an incidental finding, okay? He was not aware he had this. It was purely incidental, and very often it's picked up in that sort of way. If not, then it's often been described as a cliff, okay? Everything's going smoothly, and then all of a sudden, boom, you're over the cliff. And that's the amazing thing about the liver. It's just a really, really fascinating organ. It does so many functions, and it's a really forgiving organ. It has a high capacity for abuse. And it works really well and is forgiving until it's not. And by then, it's actually very late. And that's when it presents with complications and advanced liver disease. So if we have a way of screening early, we can effect change. Now, the part about Wayne's journey that's not typical of patients, and I think this is the engineer in him, is sort of looking at cause and effect. So he had this effect, and he needed to understand the causes and modify the causes. And that sort of lifestyle dietary change he went through is one of the toughest things that we have for patients to follow: lifestyle, behavior, and dietary modification. And when you look at the fact that fatty liver disease is the summation of many comorbidities that we've normalized in society, right? It is absolutely normal in many circumstances and societal contexts for people to expect to get diabetes or expect to get hypertension or be obese. The latest report on the state of obesity in the United States reported 42% prevalence of obesity. This is not overweight, this is obesity, okay? And so it's almost normalized in society. And for that, they will go to their physicians and get treatment. But what they're missing out on is this entire lifestyle modification interventions that we have to do. And this was one of the most interesting things about the Sun study, where by virtue of doing screening in the community and in the community among people who were not aware that they didn't know something. When people are aware they don't know something, they will go seek information. But if they're not aware that they lack knowledge or don't know something, then we have double the work to do to actually raise awareness, educate, and sensitize them to these things. But the process of screening actually was a new injection of energy into people taking responsibility for their health. So that was one of the other exciting things that happened with that. You know, we can go more into the medical side of things, but I thought it important to relate those public health and behavioral components of screening, and particularly with non-invasive testing.
Wonderful. Thank you so much. I'd like to get into some of the questions around how we get to this goal of screening 1 million people per year that Wayne mentioned. Maybe just a quick one before that, though, Neeraj, is because it dovetails very nicely with the point you were just making. We had a question come through the chat, whether NASH is irreversible, essentially, and maybe to add my own spin to that question. At what point, as you said, the liver is a forgiving organ, but there's a point at which it says enough is enough. I wonder if you could talk a little bit about where we should be intervening in that system, or where early detection, what is the point of no return? Where's the early detection going to be most effective? And if you have passed that, what can be done to reverse the course?
So that's a great question. And as a physician, I think we are often in the role of being the coach of someone's health with the use of medicines, okay? And often the perception that the medicine is the magic bullet is, you know, there, that people will find it and everything will be better. But we understand now that it's about comprehensive interventions. And irrespective of the stage, we always try, right? And even with the advanced fibrosis that Wayne's diagnosis had, with lifestyle modification and interventions, you saw his graph that he had his activity of inflammation down to 0, which is phenomenal, right? And his stiffness actually started reversing. And this is without medication, but just doing that lifestyle modification. So I wouldn't sort of say that it is irreversible. I think we can halt the progress of disease. And when we get to that point, we can start reversing things slowly. And we still need trials to actually look at what the long-term outcomes of that are. Wayne, as a patient,
yeah, I might.
Would you like to add something to that?
I really would like to. The thing is, it's not that I'm not going to be able to make all the scar tissue in my liver go away, but all I really have to do to live a decent life is to preserve enough liver function that, you know, I can have a life. And the management of liver health is a million little decisions. It's decisions every day, because if you can stop beating up on it all the time, it will do its very best to clear out the debris, and you're going to be left with a certain amount of scar tissue that is really tough. But there's a lot of scar tissue that's pretty friable. I think everybody has had cuts on their skin that over the years have faded. So, you know, if you can live long enough, you might even be able to see that all happen in the liver. But that's what happens, is that scar tissue isn't that it can't be dissolved over time. It's just that it takes too long. So the trick is all those million little decisions. And I credit my wife for my liver, because she's the owner of my liver. So everything that happens to my liver, she gets to have a vote on. But it's those kinds of it's those kinds of day-to-day be kind to yourself decisions that make it possible for the liver to repair itself.
That's great. Thank you both so much. We have Louise Campbell is raising a hand, so I'm going to try to invite her on, and we'll see if this works. Louise, you have the mic now, if you'd like to ask your question. Can you hear me, Louise? May have been a mistake or technical issue. All right, I will. I'll move on to then one of the questions in the Q&A, which is, what has your experience been with insurance companies paying for diagnostic tests and lifestyle interventions? And I think this is, you know, maybe part of the wider question, which is, how do we get to 2 million people a year, Wayne, and how has insurance been involved, and how do they need to be involved?
Well, of course, you know, in America, that's a real challenge, because we're so built to do acute response to medical issues that the payer system rewards events, not good health. So there's a lot of discussion about it, but so far it's been very difficult for people to get help. Just as an example, if you go to a hepatologist and he says you have cirrhosis, and you probably will get an interview with a nutritionist. You get probably one, but that's not what you need. You know, what you need is to have this education, is that you can learn how to translate what the nutritionist told you into how you live day to day, and we don't do that. So the support systems that we think of as patients would be part of the therapy. The payer systems thinks of as maids and you know, just assistants, and they don't pay for that. You know, they don't pay for the less than acute rehabilitation, I suppose would be one way to say it. If you have a stroke, you'll get rehabilitation care. If you're just fat, they say, go away and lose weight.
So following on that, Wayne, how do we go from, I think you've shown that beyond a shadow of doubt, for me at least, in 1,000 people, that that this approach has legs. How do we 10x, and 10x that again to get to 1 million a year? What does it look like to go from 1,000 to 10,000, 10 to 100, and then 100 to 1 million?
Well, like all of medicine and science, you know, we have to get the data better. And that's part of what comes out of our Sun 2 program is, you know, we want to be able to develop that kind of cost-related data, but there's really quite a bit of that around. It's not so much that we haven't, as a society, proven that wellness works. It's just that, you know, it's not been built into the system yet. So we're well down the road. You know, the various government programs that are starting to be more serious about obesity and wellness, and the diabetes programs, they're coming along. But the gap that we have is there's a gulf between formal medical care and the community. And there's no transitional process from the advice that you get from your doctor to how you have implemented it over time if it's not a pill. You know, doctors can give you a pill and you can go take that pill and, you know, everybody knows what that routine is. When the doctor says, well, you need to change your lifestyle and you need to, you know, learn how to exercise, go off and, you know, join Weight Watchers. You know, well, the diet industry is a $60 billion a year failure. I mean, everybody yo-yos. We don't learn how to do it. We go off and do a thing, but we can't do that. We have to change the way we think about our day-to-day, and we need help with that. And so the core of support that should exist between formal medical care and day-to-day life has to somehow be built. And that's really what we see as the Wellness League is community-based people that have the right training to carry the message of the nutritionist and the doctor into how people can change the way they think about living and those million little day-to-day decisions that make or break healthcare.
How can people sign up to the Wellness League? And there's a question through the chat what stage it's at and whether they can sign on. You've got at least one person who wants to join up on the spot, Wayne.
We actually have a consent form on our website at fattyliverfoundation.org, and that'll take you into the process. And yeah, we're still very much in the beta. So if anybody wants to participate right now, they're the earliest possible stage, but we're building an early database and developing the tools. And we're looking to, you know, in the flow of how this was supposed to be, we were supposed to run the Sun study and then stand up the Wellness League. COVID blew our whole world apart. And so since we can't do the Sun study now, we're actually pulling up the Wellness League probably a year ahead of what we had originally intended. But where we certainly welcome people to go. They just go to our site and put in the search term wellness and they'll find it.
Right. Neeraj, did you have anything to add? Yeah, please go ahead on the previous question.
Absolutely. And so with the Sun study and with the Wellness League, and the Sun study was essentially guerrilla screening. It was going out there and, you know, really educating, sensitizing people and getting them to take the test. And the whole motivation between the Wellness League, for the Wellness League, was to build that groundswell from the bottom up, create that sensitization in the community and stimulate the demand side. But that's not sufficient. That creates this wave, this upward movement wave. but we also have to have the top-down approach, and that is from the service provision side. And you know exactly how a patient who's diabetic has to go for a routine ophthalmology screen to look for retinopathy, or a nephrology screen to look at kidney function, or to a podiatrist to look for any vascular changes in the feet, etc. We need to include fatty liver screening as part of a complication screening for these other comorbidities. And if we don't include it, we're not going to pick it up. And this is the education that we have to do with primary care providers, taking care of people with these sort of comorbidities. And the hepatology world has been slow to respond to create that awareness among primary care providers, type of thing. So as a patient or advocacy organization, we're working on the bottom up, but we have to have that reciprocal sort of support and wave coming from the top down, and where the twain shall meet, you know, we'll see and create this movement. But that's the complementary effort. And this is where the screening is really important, because if doctors have the tool, if the tool is incorporated into medical management protocols and clinical protocols, then it will happen. And so that's why we need that really strong advocacy push for inclusion of this in medical management, while we push for the demand side with communities and patients.
That's great. Thank you. And I think it's a perfect segue into two great questions that have come through the chat, which are related. The first one that came through is there an aspartate aminotransferase AST blood test range which could indicate a patient has gone from NAFLD to NASH, or is a scan of the liver more accurate? And the second, I think, related question to that from another attendee is, what would be the ideal non-invasive screening method? What's lacking in the current methods? And I think these are two great questions, because you've shown data from the FibroScan as well as the blood test, which both seem really promising. So it would be great to hear from you both on what does the ideal mix look like, and also what still needs to be developed.
Who goes first here?
Okay, I'll go first, and then I'll let you fill in. So I was on a conversation on a panel a couple of days ago, and I said that the liver biopsy is so 5 years ago, and the scans are so 3 years ago, right? We're entering a new realm, and that's how it feels, how fast the field is changing, to the extent that policy cannot keep up with the changes that are happening. And so the biopsy was considered, and still is considered by regulatory authorities, as the gold standard in diagnosing. And yet we know there are inconsistencies beside sort of patients just not being happy about a huge needle being stuck in them. But there's inconsistencies in the diagnosis. Did you get the right spot? Is it representative? Despite fatty liver disease being diffuse, there are irregularities or misrepresentations in that. That being said, with the advent of scanning devices, we were getting a better picture, a global picture of the liver, and it wasn't invasive. And the question about AST is interesting, because that's a single biomarker. But what the data now is showing with non-invasive testing, the blood tests, is that there are 6 to 8 to 9 biomarkers that are being used by various screening and diagnostic and monitoring tools. And this is where big science comes in, and it's really exciting, this development over the past couple of years. We're looking at the correlations and patterns. They can actually tell the extent of liver fibrosis or fatty liver fat infiltration in the liver by those biomarkers, and looking at particular parameters on that. Now, the next step that they're looking at is seeing if they can stagger various tests, like using a biomarker blood test together with a scan, to see if they can improve sensitivity and specificity, and sort of get much more precise with the measurement of the extent of fatty liver disease. So I think it's a field that's evolving really, really fast. And I think the next step to that is linking the genetic part to it, which I'm sure you're going to go into. But Wayne, over to you on that.
Well, that really sounded like a question from a patient. And, you know, there's no simple single answer to that, because the AST, ALT tests vary a lot, but there are some general rules of thumb, if you will. If the AST becomes larger than ALT, you'd want to start getting additional data testing. There's little tests like the one called the FIB4, which combines the AST, ALT, platelet count, and age, and gives you a go, no go kind of measure as to whether you need to do more testing. But we really have come to the place where it is a series of tests in which none of them by themselves are sufficient to answer the question. And the most validated right now, as far as the research community is concerned, is the combination of the AST and the FibroScan. So that gives really interesting results that they're trying to use in research labs. We have been quite satisfied with the liver fast test that I'm using, and it's not the only one out there. I mean, there's other proprietary tests where people are doing similar kinds of things, but these are ones who take 6 to 10 blood markers and analyze them. And these are, as an engineer, I guess I'm fond of these because they were developed with artificial intelligence tools, and you know, it's really big data, and it's, I think, the future of how this works. And you will not get anything that is absolutely definitive about liver disease other than autopsy.
Great, thank you both. We've got one more question that's come through the chat, and then I'll just close out and let everybody know about next steps. So they ask, how do you see genetics playing a role in future diagnostic testing, and where are we at today, diagnostic testing and or screening?
Yeah, I think it's one of the funnest parts of what's going on right now, because habits aside, you know, genetics is critical to how the chemistry works. I mean, that is what we are. It's a chemical factory, and we got all these processes that go on. And I look forward to the time when we know, for example, as a child, that we have this tendency to have a fatty liver. I mean, there will be effective markers, I believe, that don't prove destiny. It's not destiny, but it is it's a cautionary tale, and we'll be able to use those things to think about how we want our long term to go. And I think that those kinds of tools are going to just be tremendously useful to us as we really dig into the science of it all.
Thank you, Wayne. Neeraj, anything to add to that, or else we can close out? You're muted.
Just a quick comment, and this is me putting my public health hat on and plug in for this. I think understanding the genetic association or predisposition to liver disease is just the first step. But we do know that genes are turned on or turned off or express themselves based on the stimuli in the environment, as well as the lifestyle that people live. So I think when we understand the genetic risk, that helps people make the right life choices so that they don't end up with disease. And so we need to look at it from both sides.
Yeah, that's great. And I think sitting here today, there are at least 3 genes with very well, strongly supported associations to NAFLD, NASH, cirrhosis, hepatocellular carcinoma. There will be others, but when I check clinicaltrials.gov occasionally to see what new things are on the horizon, there are already groups that are looking at the interplay between genetics and dietary choice and different diets. So as the years roll on, I think we'll continue to peel back the layers of the onion here and understand the role that it does have to play. I'm just going to take away the screen sharing from you momentarily, Wayne, just so I can show the final slide here. Great. So first of all, I'd just like to say a big thank you to Wayne and Neeraj for taking the time to take us through this and answer all the questions. Also, thanks to everybody for attending and for all the really excellent questions. As I mentioned at the start, or in case you weren't there, we will send a recording as well as a summary blog post to everyone. And please feel free to get in touch with us if you have any follow-up questions, and we can forward those on to Wayne and Neeraj as well. I'd also like to say a big thank you to Claire and Ross from our team who did a lot of the behind the scenes work to pull this all together. And I've also just plugged our podcast here. If you're interested in more genetics related things, then you can check it out. Otherwise, I think we're bang on 2 minutes to go. So thank you so much, everyone, for attending. And if anyone has any questions, just follow up with us.